today's class. So it is a condition which is in which there will be the activation of the pancreatic enzymes which leak into the substance of the pancreas and initiate the autodigestion of the gland, leading to the inflammatory conditions and causing severe pain epigastric to the patient. Okay, so there are two definitions. One is the Atlanta Symposium definition, and another is a WHO classification. It is according to the Atlanta Symposium definition. It is the inflammatory process of the pancreas with the variable involvement of all the other regional tissues or remote organ systems. It doesn't tell you about the clinical features or whatever the other condition associated with pancreatitis. So it was again defined by two other conditions in which there will be these three characteristics features, out of which two has to be present to label at a acute pancreatitis, and one is symptoms, and the main symptoms is epigastric pain consistent with the disease, means it is radiating to the back or associated with more of the meal, which has the characteristics of acute pancreatitis. The symptoms must be present, enzymes must be raised 3 times above the upper limit of the normal, and that is serum amylase or serum lipase, and especially lipase is much more specific than that of amylase. And radiological imaging consistent with the diagnosis. I have this is slightly wrong. Okay, they just correct it. Usually not with CT or MRI, it is with ultrasound abdomen only. CT we don't do for diagnosing the pancreatitis. Wrong, sir. Radiological imaging, especially ultrasound, yo CT MRI hoina. Right? So out of these three features, if any of the two is present, then we call the patient as acute pancreatitis. So there is a difference in the definition, and we follow this lower one. Okay, any or two of the three features, we follow this. This was given by WHO and Atlanta classification, revised Atlanta classification, whereas Atlanta Symposium classification just tells you that it's the inflammatory process with involvement of other regional tissues. And this is reversible one. I'm again telling you, this is a reversible pain. So etiology, whenever you are asked the etiology about the pancreatitis, don't forget the two topmost diagnosis, etiology, that is gallstone and alcohol. Rest of all are very, very, very rare. So most of the 90% you'll find gallstones or alcohol, and then idiopathic. And the rare causes includes the metabolic causes like hypercalcemia, hypertriglyceridemia, hyperlipidemia. Okay. In diabetic is also hyperglycemia also you will find it. Drugs, there are certain drugs that causes pancreatitis, and they are thiazides, azathioprine, valproate, steroids are most common. Certain infections like mumps, Coxsackie virus, there is a procedure called post-ERCP, after which the chances of pancreatitis is about 1 to 10%, and that depends upon how experienced the person is doing the procedure. Trauma, that is blunt abdominal trauma, post-organ transplantation, and post-surgical, especially involving the hepatobiliary systems, because the pancreatic duct is mobilized. So these are the common etiologies, and the most common are top 3: gallstones, alcohol, and idiopathic. So this is again the pictures. There's in center you can see the pictures of the pancreas, and the alcohol and the gallstones are the two most common causes. Usually alcohol is about 40% and gallstone is about 40%, and rest of the causes about 20%. The pathophysiology, there is the autoactivation of the digestive enzymes, mainly trypsinogen, okay, which are activated with the intestinal lumen. Acute pancreatitis results in activation of pancreatic duct system and resulting on the autoactivation of the trypsinogen, which converts into trypsin and causes edema and obstructions of the main pancreatic duct. Also in a portion of ampulla of Bader. As a result, there will be increase in the pressure, which leads to the reflux of pancreatic secretions into the pancreatic cells, causing to the inflammations and ductal injury. So, because of all this pathophysiology, there will be the edema and necrosis around the pancreas, and the patient will cause severe pain because of inflammatory markers like interleukin-1, tumor necrosis factor, all will be released. So because of these enzymes, there will be also the release of the fat necrosis in the peritoneal cavity. So the major trigger is pre-activation of trypsinogen, which is the auto activation. There will be the auto activation of trypsinogen, converting it into the trypsin, which is still in the pancreas, resulting in the auto digestion. Clear? यति मैले पहिला प्याथोलोजीमा पनि पढे होला पहिला सेकेन्ड इयरमा. The basic principle is activation of the trypsinogen into the trypsin, which causes inflammation of the main pancreatic duct and the opening of the ampulla of Vater. As a result, there will be the backflow of the fluid into the pancreatic duct, resulting in increased pressure, resulting in decreased blood flow, resulting in the inflammatory markers to be released, causing necrosis, edema, as well as release of fat necrosis. So this is the main pathophysiology. So there are two phases when we consider acute pancreatitis. Okay, there are two phases. Early phase, this is the phase that will result in main of the autoenzymes activations, and 1 week up to first week the patient may have chances of going into the severity. I will talk the severity in the next coming topic. Whereas the late phase, after it occurs after the first week, and the patient usually have a normal normalizations of all the procedures, all the pathophysiological conditions. However, sometimes the patient may persist, is still persisting for some pathophysiological changes, as a result of which there will be the collections around the pancreas, resulting in necrosis, pancreatic collection, which is also known as walled-off necrosis, pancreatic, peripancreatic ductal secretions, and sometimes as long as 4 to 6 weeks, resulting in pseudocyst of pancreas. Okay, so basically most of the pancreatitis will resolve itself in the first week, where the patient might have a chances to go into the severe pancreatitis, and this is usually in the early pancreatitis. After first week, the patient have a late pathophysiological changes, resulting in the collection all around the pancreas. There will be the collection more around the pancreas with the necrosis, edema, walled-off necrosis, peripancreatic collection. Sometimes the patient may have a cystic collection known as pancreatic pseudocyst. Severity, this is again Atlanta revised classifications: mild, moderate, and severe. Mild is with no organ failure. Moderate is transient organ failure, which reverse back after 48 hours. If it does not reverse back, it is known as severe, which is gone into the MODS, and it usually occurs within first week. So the two phases are very much important, and there is the complications like edematous pancreatitis and necrotizing pancreatitis. Usually edematous pancreatitis is a peripancreatic collection which does not involve the necrosis, occurs less than 4 weeks. And if it is more than 4 weeks, there is a pseudocyst. Okay, necrotitis means there is a necrosis all going with all those inflammatory markers releasing auto activation. There will be the compromise in the blood supply, especially first the venous supply, then because of persistent edema, there will be the arterial supply will be cut off. As a result, there will be the necrosis, and if it is less than 4 weeks, it is acute necrotizing collection. After 4 weeks, it is known as walled-off necrosis. Usually walled-off necrosis is seen after 10 days, not 4 weeks. Okay, के गाह्रो छ यहाँसम्म? Shall I move forward? Shall I move forward?
Yes, sir.
सबलाई एब्सेन्ट लेबल गरिदिन्छु है, बोलेन भने. The clinical presentation अघि पनि भने mostly is abdominal pain. Query भनेको abdominal pain को धेरै कारणहरू हुन सक्छ, and one of the cause is abdominal pain. The pancreatitis will have a severe abdominal pain depending upon mild tolerable discomfort to the severe constant incapacitating distress. भनेको पेशेन्ट चल्नै नसक्ने हुन्छ. Usually the patient will lie in typical, अझ बुक पिक्चर हेर्ने भने पेशेन्टले चाहिँ प्रेयर, मुस्लिम्सहरूले प्रे गरे जस्तो पोजिसनमा चाहिँ पेशेन्ट जान सक्छ. स्टेडी कन्स्टेन्ट पेन हुन्छ. Localized in the epigastrium and the periumbilical regions and radiates to the back, especially back, right? So aggravating and the relieving factors, query mein raheko karan there is no as such aggravating and relieving factors. The patient increases when the patient is in supine and relieved by sitting with the trunk flexed and knee drawn up position. This is the characteristics. Typical huncha, not always necessary. The patient will have in the Muslim praying positions. So there might be, because of severe pain, there might be nausea or vomiting may be present. Abdominal distension occurs if there is a peripancreatic collections, leakage of the fluids into the peritoneal cavity. There might be the abdominal distension. Sometimes there might be abdominal distension because of abrupt cut off leading to the intestinal obstructions. So when pancreatitis is extremely severe, it mimics the septic shock with the features similar to that of fever, hypotension, respiratory distress, especially ARDS, with elevation of WBC count and very tender and rigid abdomen. So tenderness is present in the epigastrium, depends upon the severity. If it is mild, you might not elicit a tenderness, but in case of severe, the patient will not allow you to touch the pain or touch his or her abdomen. That is so severe pain. There may be little or no guarding at the muscles at first, but later abdominal muscles become tender and rigid as peritoneal irritation increases. Sometimes because of abdominal distension, patient may go into paralytical ileus because there will be the massive peripancreatic seepage, fluid seepage into the peritoneal cavity, leading to the electrolyte imbalance, especially potassium, leading to hypokalemia, and patient can go into paralytic ileus. Some in advanced cases, there might be bruising and discoloration of the left flank, which is known as Gray Turner signs. It is due to the catabolism of hemoglobin. There will be the retroperitoneal pancreatic seepage and leading to destructions of the hemoglobin of RBCs. And there might be collection around the umbilicus. It is known as Cullen signs due to the hemoperitoneum. These are extensively rare and usually suggest of late pancreatic destructions in abdominal examinations. So figure yeah, sir. So these are Cullen signs in the center around the umbilicus, and in the flank there is a Gray Turner signs. So physical examination, hypo or hyperthermia, tachycardia may be present, hypotension depending upon the severity, jaundice may cause sometimes erythematous skin nodules. I told you 20% of the cases that you might find the lungs finding, especially in the left sided because of atelectasis and the left-sided pleural effusion. Abdominal guarding may be present. Bowel sound may be diminished if it is case of severity. There might be the abdominal distension and bowel sound is diminished. Pancreatic pseudocyst in upper abdomen. This is not an early features. This is a late features. Necrotizing pancreatitis. There might be Cullen signs and Gray Turner signs. Okay. So the complications are local complication and systemic complication. These are the systemic complications. The patient might go into shock because of massive. There will be so much fluid depletion because of peripancreatic seepage, because pancreatic enzymes, pancreatic have a lot of fluids, around 1 to 2 liters of the fluid are secreted at after each meal. So there will be this leakage of the fluid in the pancreatic bed, and ileus might also develop. Hypoxia because of ARDS, hyperglycemia because of pancreatic islets. You know, beta cells is present in the pancreatic islets, and it's in the one of the part of the body and tail of the pancreas. So whenever there is enzymatic destructions of the pancreas, there will be the disruption in the pancreatic islets and resulting in beta cells destructions, resulting in decreased insulin secretion. As a result, there will be the raised blood sugar. Hypocalcemia is because of fat necrosis, resulting in the sequestration of the calcium. Hypoalbuminemia is because of increased capillary permeability. There will be the decreased oncotic pressures, and all the fluids, proteins will be lost in the pancreatic fluid, resulting in hypoalbuminemia. So the local complication includes pancreatic necrosis, pancreatic abscess, pancreatic pseudocyst, and pancreatic ascites, which you will be dealing more commonly in the surgical topics. Some of the GI complication includes upper GI bleeding because of the patient might be a severe gastric erosions. There might be the duodenal erosion. Sometimes pseudoaneurysm is present. Pseudoaneurysm because of acute pancreatitis, especially seen in acute and chronic pancreatitis. Duodenal obstruction sometimes because of the pancreatic mass. This is usually the features of acute and chronic. Obstructive jaundice also the features of acute and chronic pancreatitis. That's a different entity we'll discuss later in the chronic pancreatitis. So the enzymes, as I told you, 2 enzymes that is very much important in the definition also, pancreatic lipase and pancreatic amylase. So pancreatic amylase, serum amylase is one of the sensitive marker which usually rise within 4 to 6 hours of the onset and usually present within 24 to 48 hours. Usually increased in the first day of the symptoms and remain elevated usually 3 days, not up to 5 days. It is highly sensitive with the sensitivity greater than 85%. Okay, and even in the simple mild pancreatitis, it might be increased. So sometimes you can see in case of acute attack superimposed on chronic pancreatitis, which is also known as acute on chronic pancreatitis, it might be raised, but not to the level. Usually, it is more than threefold, is labeled as a significant elevation in for the diagnosis the conditions. This is not specific. There are certain conditions there in which the pancreatic the serum amylase level might raised, and they are salivary gland disorder. Salivary gland also have amylase level in secretions, perforated peptic ulcers, mesenteric ischemia, especially and in case of chronic renal failure, the amylase level might be raised. So usually it turns normal after 48 to 72 hours, and even with continuing of the pancreatitis. So after this, the lipase level is much more specific, which remains high up to 14 days. So persistent elevations might suggest another diagnosis like pseudocyst, pancreatic abscess, or non-pancreatic cause like intestinal obstructions, mumps, narcotic drugs, etc. So serum lipase, it is also elevated more than 3 times, but see, the sensitivity is much high, and this is much more specific because it remains elevated persistently even beyond 3 days. So this is the much more specific enzymes reliable for diagnosing acute pancreatitis. Other lab findings, this is just simple. There might be elevated WBC count, glucose might be high, serum calcium might be low, LFT might be deranged, LDH might be raised, which suggests a poor prognosis. C-reactive protein might be raised, and ABG might show hypoxia, especially in case of effusion or ARDS. So ultrasound is the diagnosis of the choice. In the first 3 days, you go for ultrasound, not CT and MRI. They might, but the reliability is very questionable because ultrasound might not always show the pancreatic visibility. So you have to sometimes think of other than ultrasound. And there are we got options as brain X-ray abdomen. CT scan is the gold standard for diagnosing pancreatitis. If the CT scan shows pancreatic inflammation, it is almost sure that the patient is having an acute pancreatitis. So this is a term, Ranson's prognostic criteria. This is you have to mug up. It's very difficult. This is the criteria to see if it has a prognosis. What is the prognosis factor? You can see within 48 hours and at the time of admission and after 48 hours. These are all the parameters, and these are 2 gallstone pancreatitis and non-gallstone pancreatitis. So 2 different criteria you have to mug up, no choice. This is the most commonly asked. There is another prognostic criteria which is known as Glasgow criteria. You might learn in surgery classes, but this is not absolutely required because it's very difficult. We have another classification, BISAPS classifications, which we follow mostly. So these are the differential diagnosis. Basically, management. So management. Most of the management includes the first and foremost step is pain management, IV fluid loss, oxygen. हजुर हजुर सुनिरहेछ Okay. So management, the first and foremost management is IV fluids, because there will, as I told you, there is a massive fluid loss, massive, more than 3 liters, sometimes 6 liters of the fluid can loss. So the first and foremost important point in the management is IV fluid, intravenous hydration and adequate analgesia because of severe pain. These 2 are the gold standard or core step in the management of acute pancreatitis. Intravascular fluid usually should be replaced within 200 to 400 ml per hour in the first 24 to 48 hours. After that, we analyze the patient whether the patient is severely depleted or not. Then we decrease gradually the amount of the fluid. Some of the severe disease may require up to 10 liters of the fluid. So this is the severity. The patient will die because of hypovolemia, and the patient will go into shock. So this is the first and the foremost step in the management of acute pancreatitis. The patient is kept nil per or oral until any nausea or vomiting have subsided because of severe pain. For the pain, you can use simple painkiller, sometimes morphine or opioids might be used. Oxygen for hypoxia may be used, and the ventilation is required if the patient goes into the ARDS, which is the features of severe pancreatitis. Opioid not always required. It adjusted on the daily basis according to the ongoing needs. Simple painkiller is usually sufficient. Nasogastric intubation, NG tube is not routinely passed. Previously, you will see the NG tube was routinely given, but nowadays we don't go for routine NG tube insertion. Okay, PPI, they say, according to the book, they say it is not beneficial, but we frequently give the patient a PPI because most of the patient have alcoholic gastritis, and that causes the severe GI bleed. So PPIs are frequently used. Sorry. The patient should be carefully monitored for any signs of organ failure within as early as possible. Hypotension with vital signs, urinary output, because as I told you, there will be the massive fluid loss, and because of which the patient can go into the sepsis at any time. Tachypnea should not be assumed due to the abdominal pain. The patient has likely chances of going into ARDS. So any possibility of tachypnea or decreased oxygen concentration, the patient should be evaluated for respiratory dysfunction. So patient should be given oxygen supplementation. Who exhibits early sign of organ dysfunction should be immediately transferred to the intensive care unit. So surgery as such, there is no role in acute pancreatitis until and unless the patient has recovered and there is some complication in case of pseudocyst of pancreas or necrosis, severe necrosis, where the patient will have a collection, and that is very, very, very rare. So this is the core step in the management of acute pancreatitis. So any questions? Any question?